This conference will now be recorded.
Okay, hello everyone. Um, my name's Derek Sanders. I do work for Remedy Senior Care. I'm their lead consultant pharmacist for the excuse me, Southwest region. Um, One of the things I'll tell you today is um, you're going to be eventually all administrators, and it's an important job and it's a very tough job. And so there are different aspects of the job that, I mean, you can't have your hand on everything, but it's always important. And I like to do this presentation because there's things that are going to come up. And you can't have your hands in everything. You're just one person, but you need to know kind of the things that you'll be talking to your director of nursing about. And with pharmacy, there are certain things that you need to be aware of, and there's just a few kind of key points that you can always check in with your director of nursing to see where you're at in your facility. Um, so it's always important as a consultant. My rule of thumb and the consultants that work for me is that communication is just not with the director of nursing. It's also the administrator to kind of give them a kind of a map of how things are going and things like that. So we're going to be going through some regulations, and this was such a big regulatory change as far as um, pharmacy is concerned. It was so big they had to do it in 3 phases, and we'll kind of go over it. But it's really the hot point in pharmacy, and there's a ton of regulations with pharmacy and everything else. So, but we'll hit on these because these are always uh, they're very critical, especially during the survey process. And so it's something that you can check in with the director of nursing on because the state will definitely be looking at it. Phase one, it started November 28th of 2016, and nothing really earth shattering here. It was really kind of really just getting the ground or the foundation set for following regulations that were coming up in phase two and phase three. Um, so the pharmacist must report irregularities to the attending physician, director of nursing. And what changed here was they included the medical director. And sometimes the medical director wasn't the attending, and they just wanted there to be a more uh, streamlined kind of that everybody was aware of what was going on in the facility. So, as far as any irregularities concerning a resident at the facility, the report must include resident's name, relevant drug, and any irregularities. Uh, The response to any pharmacist reports, the attending physician must document in the medical record. And that medical record can be it can, as we are right now, we have a lot of electronic health records where they're able to respond. Typically, it's still on paper and those are scanned in, but it has to be a part of the record, that document that comes from the consultant pharmacist to the director of nursing, and they share that with the attending physician. So they should be able to prove through that, the irregularity has been reviewed, the action that has been taken to address the irregularity, if no changes, and this is the one that really gets, and I get it, physicians are busy. I mean, they're running and gunning just like everybody else is. But there should be some sort of rationale of why, if they didn't want to change a medication, or they felt like that therapy, was fine for that resident, they need to document some sort of rationale as why they didn't agree with the recommendation. So that one's sometimes a sticking point because sometimes you have some physicians that'll say, because I said so, and that's not really the rationale we're looking for. Typically, rationale, what you're looking for is, it could be something like, if it was an antidepressant or some sort of psychotropic medication, they could say, hey, in my medical opinion, any reduction of dose would increase symptoms and decrease quality of life. That would be a more accurate rationale and acceptable. Policies and procedures for drug regimen review. The facility must develop and maintain policies and procedures for the monthly drug regimen review. And one thing they're really looking for here is time frames of when the recommendations would be answered. Okay, and they also identified you're going to have two types of recommendations that the consultant is going to basically deliver to the facility. And one is going to be an urgent recommendation. The other one would be a non-urgent recommendation. And typically, facilities, I always tell them, policies are good, but policies shouldn't paint you into a corner either. You don't want to ever set up a time frame that's going to, you don't write a policy that sets you up to fail. So typically in my facilities, when I have helped them write these time frames, when this regulation came out, a non-urgent recommendation would be within 30 days. An urgent recommendation, if I'm the consultant, and I always recommend this to all the consultants, is if it's an urgent recommendation and it's something that could affect the health and safety of a resident, then while I am consulting at that facility at that time, when I see the irregularity, I'm printing that recommendation out. We're delivering it at that time so it can be acted on. As far as the policy goes for the facility, I will say an urgent recommendation, I would always tell them the time frame for that would be 24 hours. So that's kind of what I would set up as a policy for time frames for recommendations. The updated definition of irregularity, I will just tell you that an irregularity, the threshold is very low. And so when your consultant is looking at a medical record, having one blood pressure measurement that was not taken, and there's a blank on the MAR showing that it wasn't documented as being done, once out of the 30 days or the month is an irregularity. So it's a low threshold. It's typically something that consultants will look at and they'll say, hey, I do see blanks on the MARS. We need to talk to the, CMAs or the nurses about doing a better job of documentation. So that irregularity, just remember, it's not always a big time. An irregularity is just not a big time drug interaction or a mistake. It can be something it's very, very low. So it can be anything. A lot of deficiencies that you'll see out there in pharmacy will be always unnecessary drug. And I will tell you that an unnecessary drug, you can make any medication in certain circumstances unnecessary. So typically if it's used in an excessive dose, excessive duration, without adequate monitoring, if you're not using it for the proper indication for its use, in the presence of adverse consequences, or any combinations of those reasons. So unnecessary drug is, it could be somebody had a cold a year ago and is on an antihistamine and something like Claritin, and a year later they're still taking it, even though they're over the cold. That could be an unnecessary drug. So thresholds are very, very low when you start looking at these things, and they're easy to be, you can always make a case for something a lot of times. So phase 2 is November 28, 2017. There was a lot of debate when you started looking at this initially when CMS put it out. They had an updated definition of a psychotropic drug, and their definition is very broad. But it was a drug that affects brain activities associated with mental processes and behavior. Initially, when they brought that out, they did not. They included some other drug classes besides just antipsychotics, antidepressants, anti-anxiety, and hypnotics. They did try to rope in, within that definition of a psychotropic, they were trying to rope in opioids or pain medications. And they did back off of that. There was because it could have caused some issues. But I'm not a big fan of the definition, because if you think about it, there is there's just a wide array of medications that can affect brain activity. So it's almost a regular, the way the definition is, it's almost impossible if they would have just left it like that. So all psychotropic drugs, they'll be held to the same standards. GDRs are gradual dose reductions and behavioral interventions for all psychotropics.
What does GDR stand for?
Gradual dose reduction.
Thank you.
Another piece of this, PRN psychotropic drugs, or just as needed psychotropic drugs, they would be limited to 14 days. So antidepressants, anti-anxiety, something like, Zoloft, which typically antidepressants, it's not really a PRN medication. You're either on them or you're not. You could potentially have a trazodone at bedtime that may be PRN, but typically that's not even the case. A lot of times what you run into is something for like lorazepam or Ativan for anxiety, and those are limited to 14 days on an as-needed basis. So, or you'll have a hypnotic. It could be Restoril or temazepam. for PRN insomnia. But it can only be done for 14 days. But if they want to extend a PRN order past 14 days, the prescriber has to document rationale in the medical record and indicate the duration of the PRN order. Now, I will tell you, in my facilities that I consult at, nowhere in the regulations does it give you it doesn't say how long that duration has to be or what it cannot be. Rule of thumb for me is 6 months if it's something that patient, or resident really needs. And typically, your rationale is going to be, something in the nature of this resident requires periodic dosing of this medication due to increased anxiety symptoms, stuff like that. But I don't recommend. There are some facilities that'll write the order for 14 days and they just rewrite the order every 14 days. And I try to get them out of that because it's something that can come back to bite you. But I would do 6 months stop date on something that resident needs and have the appropriate rationale on there, because there's no duration it doesn't define how long you can do it. And talking about rationale, there again, you have to look at appropriate rationale from the physician. So I've had physicians say, until I say to stop it, or until they'll say until the end of time. So they'll say all kinds of stuff, but that's where your consultant and your director of nursing can kind of help with that. PRN antipsychotics, they are limited to 14 days, no exceptions. And that would be something like PRN Haldol, PRN Zyprexa, something like that. They cannot be renewed unless the prescriber evaluates the resident for the appropriateness of that medication. And after the evaluation, a new order could be written for 14 more days. Now, I will tell you that PRN antipsychotic, that will be, I will tell you that this is, in this day and time, it should be an in-person evaluation. Can't be a phone call. Telehealth, if it's a FaceTime or something of that nature, that would fly, especially within the environment we're in right now. So that would be acceptable, but it does have to be that way every 14 days. So other requirements they had in November 28, 2017, phase 2, all facilities had to introduce their plan, their QAPI plan, their quality assurance performance improvement plan to the state survey agency. And the facilities had to develop antibiotic stewardship, antibiotic protocols, and a system to monitor antibiotic use. And that's one of the pieces that still today that you get into that sometimes it's not as complete as you would like. The other piece in that was the discharge summary, medication reconciliation, pre-discharge and post-discharge medications. And that would be basically a task that your charge nurses who are admitting or discharging patients or residents out of the facility. That would be that's typically handled by them on the floor. But you do have to have a process in place, and a lot of times electronic health records makes that easy. But it's still another piece that you have to be able to show the process to, the surveyors have asked about it. So this is kind of, especially when these regs came out, you're all guessing, how is this going to look during a survey? And you kind of feel like you're trying to, you're trying to look ahead and go, gosh, how's this going to all work out? It is, and back in this time, they had the new survey process instead of the traditional, and things kind of changed. You saw a change from used to surveyors would come in and it'd all be pen and paper, and now it's more of, it's on computers. Things are kind of moving them through the process, and so you're seeing that. So it was a big change in that time when they started using the computers and having that program kind of guide them through the survey process. One thing I want to touch on, and a lot of times people get confused about it, and it's regulation versus guidance. There's documents that are put out by CMS concerning regulations, and they give guidance to the surveyors on how to do things, how to find deficiencies within that regulation. So if you'll look at this, there are portions of the interpretive guidelines that specify such things as permissive duties or tools that facilities they may be using to care for residents. Permissive duties are not requirements, and the lack of any use of any particular tool, it doesn't constitute, a deficiency just on its face. Okay. In the interpretive guidelines, they may say this could be done whatever, but in short, just looking at all of this, just to basically simplify it, basically a surveyor can't cite a deficiency based on the interpretive guidelines or the guidance that they receive versus what the regulation is. And what I mean by that is in the guidance, if they, talked about doing a certain process a certain way, as an example, it doesn't mean if they come in your facility and you're not doing it the way that guidance or interpretive guidelines gave an example of, it doesn't mean they can cite you because you weren't doing that task like it was described. So they would have to show in the regulation what was wrong versus what the guidance was showing. So they must base all cited deficiencies on a violation of statutory or regulatory requirements rather than sections of the interpretive guidelines. And so you're really, and that's what we were talking about. I was just talking about, it has to be part of the regulation. You can't use the interpretive guidelines to cite a deficiency. So it's something that sometimes that you may have a physician I've done it, and I have a good relationship with the surveyors, but I will, if there's a deficiency written and they talk to me about it, a lot of times I'll go over the regulation and we'll talk about it, and sometimes you can kind of show what the facility is doing, and in fact they probably are satisfying the regulatory requirement. It just may not be how the guidance or the example that was given. It may be just a different form of achieving the same goal. So it's just something to keep in mind, and it's not typically, depending on who you work for, they have management that kind of looks at these things as well to make sure they don't get a deficiency that's based on guidance rather than regulation. So must versus should, words mean things. And so, you can always, when you look at the regulations like unnecessary drugs, abnormal or toxic serum concentrations must be evaluated for dosage adjustments. So, you're stuck there. They must be evaluated. The facility should have a procedure for how to resolve situations where the attending physician does not agree or take action on identified irregularities. You should have a procedure. It may not be exactly what may be in the guidance that is set forth to the surveyors, but it may achieve the same goal. And one thing to always keep in mind, and people get stressed about surveys, and I get it to a certain extent, but it's always good. Don't get too crazy with them. I mean, and what I mean by that is getting just over anxious. You're going to get questions. One thing I will tell you is there's no regulation that says when a surveyor comes and talks to you or any of your staff about a possible problem, there's no regulation saying you have to just tell them the answer right there. What I always recommend is you gather your facts and just tell them, hey, let me look into that, and we'll bring you the documentation or supply that answer here in just a second. And just gather your facts and then go give them the information that they've requested. The other thing, you always have to be in mind that surveyors, they might not ask the question that gives you that makes you think this, but always remember in the back of your mind, they're looking for a process, okay? And the question may not even be it may not sound like that's what they're looking for, but just keep in mind, they want to know what your process is for certain things. So it's just, if you kind of think that way, if they come and talk to you about drug destruction or something like that, well, you're going to get your DON together and y'all will talk about, here's the process. This is how we do this. This is who this is handed off to. So everything they're looking for is how the facility functions and what's the process. Even though the question, they're not just going to come out and ask you what that is. So be sure and keep that in the back of your mind. So medication management, risk reduction, all of those are always going to be evidence-based, standards of care, risk benefit, resident surrogate involvement. So, and the only thing we're talking about on that is within the guidance, they may have given an example of a medication that is probably 80% of the time should not be used in a geriatric patient or resident, but not everybody's made the same, and there may be some evidence that that medication is needed to increase the quality of life of that resident. So that would be something that you would have some sort of rationale saying why it was being supplied for the well-being of that resident. So there's certain things, you just kind of have to have your T's crossed and your I's dotted on some of this stuff. But just because it's in the guidance, as an example, it's actually the regulation that has to be followed, not really the guidance. So we talked about irregularities earlier, and I told you about irregularities, I can make a glass of water an irregularity. If I'm looking at a chart, and what I mean by that, you may have somebody on fluid restriction, and if your facility's giving them too much water, no, it's not a medication, but it is an irregularity for that resident. It would be something that could cite as a deficiency. So there's not anything medication-wise. I could make a case for just about anything in the right situation. So a lot of people will think, oh, it's just your psychotropics, your antipsychotics, anxiolytics, hypnotics. Those are where all the irregularities are. And typically it could be, a lot of times it's cough and cold things. So it's just it could be applied to just about any medication. Pharmaceutical services, this is really wordy, but I will tell you to shorten it up. Basically, pharmaceutical services is from the time that a prescription leaves your facility on whether it's through an electronic health record or it's faxed to our pharmacy, everything from the filling of that medication, the delivery, and its arrival to the facility, and then its storage at the facility until it's administered to the resident. All that at the start to the end and everything in between is all pharmaceutical services, and includes everything around it from administration to monitoring and discontinuation and everything in between. So it's a big pharmaceutical services encompasses a lot of things, just not just not the administration or the destruction. Everything from the time it gets to the pharmacy to the time it's either destroyed in the facility or discharged home with the resident or administered. Everything in between on the front end and back end. So if you're not confused by now, this is a lot to digest. This is my picture of, and she's not really a surveyor, but I get this look sometimes from surveyors, and you will too in the future. But like I was saying earlier, just keep calm, gather your facts. You don't ever have to talk, off the cuff. You can gather your data and deliver, the information. So this is what I was talking about irregularities. And these are just some examples about, we talked about a low threshold. And so like a hold for a DIG, if you're going to hold the dose for any pulse that's less than 60, if I looked at the MAR and there were 2 blanks or no documentation for 28 days, then, that's an irregularity. If you have 6 carts in your facility and I go through all 6 carts and I find 1 insulin vial that's not dated, that's an irregularity. All of these are examples of irregularities and something that your pharmacist should basically point out to you and say, hey, this is what I had on this, and it's something that should be addressed. So it's just a low threshold as far as when your consultant comes into the facility. It only takes 1 missed, dating a vial. So it's important that kind of everybody, your processes for certain things are all being adhered to. So there's our low threshold. It feels like that sometimes. And so person-centered care, to focus on the resident as the locus of control and support the resident in making their own choices and having control over their daily lives. You see that a lot in facilities. I want to caution you, though, about there's a lot of times you do see person-centered care. It's kind of, especially right now, it's difficult because of the COVID issue that we have, because you have a lot of facilities will have dedicated halls for any COVID issues. And so this is kind of, person-centered care is kind of, it's a tough, even when you don't have COVID, it is tough because you have a lot of different wishes. And in short, just to summarize it, all person-centered care is how is that resident doing things when they were at home? Is essentially how it is. And you'll see facilities that will have, from a medication standpoint, they may have morning medications given from 8 o'clock to 11. And that's just so, people don't have to get up early. They can do it like they were doing it at home. And they will give medications kind of like they were doing at home, unless it's a safety issue or something where you're not going to give sleeping pill in the morning, but that's basically the big deal behind person-centered care. Planning and implementing care. The resident has the right to be informed of and participate in his or her treatment, including, the right to be fully informed about their health status, medical condition, right to be informed of, the type of caregiver or professional that furnish the care, and the right to be informed in advance by the physician or other health professional of the risk and benefits of proposed care, of treatment and treatment alternatives. Where this fits in with pharmacy is, and sometimes you'll see this, that say a resident has a UTI and they have good cognitive ability, they're with it. The facility should have a process where the resident is told about the medication that is being prescribed, the potential adverse effects of that medication, the potential problems if they don't take the medication, and and they just need to have that information up front. And that's typically where I see Sometimes it doesn't happen, and the survey teams may have an issue with it. So it's not a huge. There needs to be documentation in the medical record that they were notified of the risk and benefits of the medication, risk and benefits of not receiving any treatment, and just getting their okay for that medication. So treatment refers to, this is the guidance, treatment refers to medical care, nursing care, and interventions provided to maintain or restore health and well-being, to relieve symptoms. You could call it an informed consent in a way. I mean, it is. It's not on they're not saying that you have to have a form or anything, but it is sort of like an informed consent. If you take the example of an antibiotic, it's not any different than what we get, at home from our physician and from our pharmacist when we go pick up the medication. You're being informed about the medication, and you've made the decision to take it, and that's basically what they're talking about, is giving them, they have some say over their health care. This is kind of an example of, and this is what I was talking about earlier, and you've got to watch this. I don't see it a lot in Oklahoma, but residents have the right to sleep, and if they want to get up at 9 o'clock in the morning, things should be adjusted to them. If you shouldn't be waking people up at 6 in the morning and giving them meds. You see the example of 6 a.m. Synthroid. That could be something that your pharmacist your consultant could talk to the physician or the nurse, and we could change that maybe to bedtime, so they don't have to get up to take medicine. So I don't see a lot of deficiencies for this, but it could be, you could see it, and it could be an issue. Not to mention it could cause other issues, as far as if you're waking people up that need, extra rest, or you're putting them out of their routine, then you're going to be dealing with behaviors, possibly, or other things like that. So it's always a good idea to kind of, if a facility you're in doesn't have something like this, it's kind of open up the med administration times and really try to make it a better thing for the resident, something they're more accustomed to. If they're needing extra sleep, you don't want to interrupt that. But I see this being a bigger deal in Oklahoma probably in the future, but it's just something you need to be aware of. Irregularity, use of medication that is inconsistent with accepted standards of practice. I mean, it could impact you. Probably the biggest one is with the antipsychotics being used with dementia-related states. And, it is true that antipsychotics in elderly patients with dementia have a higher mortality rate. And so it is something that every state has really put focus on, and surveyors will continue to focus on it, and rightfully so. But you just need to be aware of it, that's really going to be one of your highlighted areas that they're going to be really looking at for. One of the things that you will see is resident rights versus facility responsibility. And this is something that I see sometimes, but you look at while federal regulations affirm a resident's right to participate in care planning and to refuse treatment, the regulations do not require the facility to provide specific medical interventions or treatments requested by the resident family or a resident representative that the resident's physician deems inappropriate. Okay, so you may have a resident or resident's family requiring a certain treatment or whatever, but if the physician deems it inappropriate, it doesn't, yeah, they have rights, but a medical professional, a physician, may not see that as being inappropriate. It may see it as being inappropriate. So the facility is not required to do anything. They're not going to be in trouble with a deficiency or anything. So permission given by or a request made by the resident and or representative does not serve as a sole justification for the medication itself. If you look at what I will tell you on this and where you really see this take place, and you've probably seen it, if a family member comes in to the facility to visit their loved one and say they're the power of attorney, and they say, well, whenever mom or dad acts like this, it must be a urinary tract infection. We need an antibiotic. Okay. And so the nurse calls the doctor. The doctor doesn't do anything as far as laboratory testing, or the nurse doesn't go down and evaluate the resident, and they just prescribe the medication. Just because the request was made by the resident or the resident's family, it doesn't absolve you. It would be an unnecessary drug. So you still have to have processes in place, even if they can request it, and that's fine. But there has to be a need for the medication, and the proper steps have to be made in order to justify the use of that medication. So you typically see that with antibiotics and psychotropics. So you got to be careful with that. If a resident refuses any treatment or services, now that refusal, it doesn't absolve the facility staff from providing other care. So, if you had somebody that, if they're refusing food and fluids and they're nearing death, that doesn't absolve the facility staff from still providing them appropriate measures for pressure injury prevention or anything like that. So there still should be basic care that will maintain, the highest level of physical, mental, and psychosocial well-being, even if they've refused the treatment or services. So just keep that in mind. When the resident request is something that the facility staffs would place the individual at risk, the resident chooses not to use a walker recommended by therapy or something like that, there should be a process in place to examine the risk benefit and guide, some decision making about it. And that's kind of why you have a team approach to certain aspects of that. And a lot of times you're really going to have to lean on your nurses and your physicians to kind of look for either alternatives, because just because they say, I don't want to use a walker, it doesn't mean that you have, it doesn't absolve you from help finding an alternative or another process to make sure that they're safe. So it's a lot to digest, but they do have the right to refuse certain things. So, well, they can refuse treatments or anything like that. Pain management. The facility must ensure that pain management is provided to residents who require such services. One of the things I will tell you is that pain management, I mean, it can be tricky, especially with in geriatrics. But you have to have, you got to be consistent with the standards of practice, and basically working with therapy and all of that stuff. But there are non-pharmacological and pharmacological interventions and approaches. And so this is where your therapy piece comes in, using those people to help, maybe help with getting them the physical activity that will help with chronic pain. And then you have your opioids, and your physicians will be guiding that, but the facility still has a responsibility to make sure that those are administered appropriately, that the residents are aware of the risk and benefits and all of that good stuff. On your MedPass in a facility, when surveyors come in, they're going to be watching medication passes by CMAs. In long-term care facilities, you have to have an error rate of 5% or less. And it's not always, I don't typically have a bunch of those. I have pretty good CMAs in the facilities we go to, but you always want to do well on your medication pass. I mean, they're hard to clear once they come back. Everybody's nervous and things like that. But this is something your pharmacist can help you with, your consultant. And so they will kind of guide you through this, but this is where you really have to lean on your consultant pharmacist and make sure your staff is prepared with the procedures and things, where your DON and consultant can really make sure that they are helping them be proficient. So, and then we talked a little bit earlier about a person-centered MedPass. The adjustment of medication administration times. If people want to sleep, you can't wake them up at 5:30 in the morning. If they complain, they would count that as a medication, not an error, but they would count it as, it would definitely be figured in on the MedPass if there were complaints by the resident that, hey, they wake me up at 5 in the morning to give me a medication, then I can't go back to sleep. That's going to be an issue. So we already talked about person-centered MedPass earlier. The infection prevention and control program, the facility must establish an infection prevention and control program. And typically that's going to be your director of nursing They're kind of their job, or the ADON, the Assistant Director of Nursing, but they have to have some antibiotic stewardship program that helps them. And most facilities have it, just not to the level of when these regulations came out. They do track antibiotics and infection rates and things like that. But what really needs to be looked at is, with an antibiotic stewardship program, are those processes being followed when say a family member says, oh, mom needs an antibiotic, and there's not a UA drawn or anything. There's no blood work. If you're looking for a UTI, you didn't do any of the evaluations. The medication was just prescribed. That's where a survey team would hit you, is in here in the infection prevention, in this area. It would be in an infection control deficiency, but they would also cite a deficiency in this area because you didn't have anything to detect that. Your staff wasn't using anything to guide them through the proper procedures. So, and this is just a lot more of talking about antibiotics stewardship and its development. I won't go into all of that, but it requires a lot of people's input, from your medical director, consulting pharmacist, nursing, and everyone. But they're not hard to get into effect. I would be curious. I always ask, even when I get a new facility, I will ask what their antibiotic stewardship program looks like. And a lot of times I'll make recommendations if I don't feel like that if there may be some pieces of it that need to be implemented. So it's not a bad one to look at from an administrator's at least check on, and make sure that the director of nursing has this up and going. And then these are just some more examples about drug irregularity. I think we beat that with a club here. Okay, psychotropic drugs, you just have 4 categories: antipsychotics, antidepressants, your anxiolytics, and also your hypnotics. Of course, with the regulations, residents, you're basically not going to give it to them if they don't need them. Okay. The big thing with psychotropic medications is you've got to have the documentation to support the use of it. Okay. And so that's the big thing. And documentation is going to clear up everything. So you always have to, and my job as a consultant is to make sure that documentation's there. And so that's what I do a lot, is look to make sure that we're doing things. If they're using psychotropic drugs, we do have to have gradual dose reductions. There should be some sort of behavioral interventions in place. The only time we wouldn't, you still have to ask, but you're not expecting a dose reduction, but in certain people, it'll be clinically contraindicated, and it may be the right medication for that person, but you just have to have the documentation in order to support the use of it. And typically, it's not hard to find, especially if somebody really needs the medication. You're going to have plenty of documentation showing behaviors that are either harmful to themselves or harmful to someone else. And the facility they have the responsibility to protect everybody, including the resident that's being treated. So it could be something that is maybe not the best in the geriatric resident, but would any reduction would be clinically contraindicated. We talked about PRN orders for psychotropic drugs are limited to 14 days. We did talk about the everything except the antipsychotics. That's a 14-day hard stop, and you have to have an in-person evaluation to extend it another 14 days. And so now on your anxiolytics, hypnotics, and antidepressants, they can put the duration for the PRN order. If the doctor puts indefinitely, that's not going to fly. We really need a real duration. They could say 3 months, they could say 6 months, whatever, but indefinitely would not work. So one thing that I will tell you on PRN orders for antipsychotic drugs, one thing you'll get into is with hospice. And I will tell you that there's no exclusion. Now, what I don't agree with that, but like PRN lorazepam, I think, it's needed in a lot of hospice residents. PRN compazine, it may be needed for certain geriatric hospice residents. Compazine's used for nausea and vomiting, but its chemical class is an antipsychotic compound. So they still consider that a PRN antipsychotic. So it would be every a PRN lorazepam, you could do a 6-month stop date on, but a PRN Haldol or Compazine in a hospice resident, it's still going to be the 14 days. And so I don't really agree with it because I know that in a hospice resident, end-of-life care is difficult, and but they just haven't made a lot of changes to this. I think they're coming, but not anything with the government's not real fast. So we did talk about the drug regimen review earlier. It's reviewed at least once a month by a licensed pharmacist. We talked about irregularities. And having the presence of that recommendation that is acted on in the medical record, signed and dated. Hold on just a second. Okay. So drug regimen review, it's going to be a pretty thorough evaluation of the medical record. Consultants are not going to go through every MAR. They're going to look for trends, okay? Now, I will tell you that I go through every med cart. Now, is it each individual? I'm looking for trends. It's kind of like a sampling. So it's not going to be every thing, and you can find trends. It's pretty easy to see blanks. So your consultant will be looking at that. Your nursing staff in your facilities, they need to pick up kind of, your consultant's only going to be there once a month, but there should be, ample time at the end of shift, beginning of shift, for a nurse to look through their cart when they're restocking, things like that. So, yes, your consultant comes in there, but they're not going to be they're not going to be able to go through every nook and cranny, of the med cards and your med rooms, unless you're willing to pay that bill. It would take a long time, but you got to have some nursing involvement, not just nursing, but CMA involvement on the med cards and things like that. This is just an example, and you can always look at this. This is what the surveyors use when they come into the facilities to kind of check things off, but these forms are available. You can look at them, and it just kind of shows kind of how they're going through their survey process. I think I found this one on the internet somewhere, and so, but I think you can go out to CMS and look at something like this. We talked about urgent actions and non-urgent recommendation, and I talked about, if you identify, if I'm the consultant, I'm printing that off right there, okay? And so, the on this slide, the big thing on this is any urgent recommendation. We talked about in your policy, I would say 24 hours would be your time frame that you're going to resolve those. But what I will tell you is, if your consultant, if there's anything urgent, it needs to be that day. I mean, it needs to be taken care of when they find it. So, and that's what we do. And the consultants that I manage, that's what they do. And it's because it's the right thing to do for the resident. I mean, it's no different than if I was at a Walgreens or anywhere else. Once I saw an issue, we take care of it then if it's an urgent matter. This just notification of changes, anything changes, you have to inform the resident, consult with the resident's physician, just change of condition, falls, anything like that. That is pretty self-explanatory. And this is just going back over the pharmacist must report any irregularities. We talked about that. Sometimes you'll get into issues of, and I will tell you as an administrator, what you will, if I came to a facility you were administrator of, I might need your help. And one of them would be if I'm turning my recommendations in every month and I'm not getting any traction from the physician. The director of nursing is pulling her hair out because she can't get recommendations acted upon. That's when we're coming to you and saying, hey, can you help us? We need to talk to the medical director. And you kind of got to get everybody involved, the medical director and the administrator, to talk to the attending to make sure they get those answered. Most doctors are pretty good. Occasionally you'll get, some that are just overwhelmed. Does anybody have any questions? And if you need to, we've got one more slide deck, but we will take a 15-minute break, and then we will start that up after that 15 minutes, if that's okay with y'all.
This conference will now be recorded.
Okay, this is drug diversion, basically best practices, and deals with what you would do as an administrator, kind of what you're looking for as far as, when drug diversion happens, what processes you need to be aware of that you need to go through. And this is one of the things, and I like to cover this because it's not it's not if it's going to happen. Yeah, I mean, it's going to happen at some point during your career, and you need to know kind of how to handle things as far as what you need to do and what steps you need to take. And so it's really, I'm not trying to downplay it. I'm saying don't get out of sorts about it. It's serious, but you need to, keep your calm and just handle the situation. But we'll kind of go over some of that and things you can look for, and just need to be careful. Drug diversion, a lot of people, when you say it, yeah, we're concerned about controlled medications, your controlled substances, but there's also diversion of non-controlled medications, and that's something you need to be aware of as well. And we'll talk about things that can limit that. The thing that you need to realize is that you have to have processes in place that will detect diversion. And we'll kind of go over some of that in here, but we're also going to look at basically characteristics of people that might lead you to you or the director of nursing, little telltale signs that pop up that you can kind of grab a hold of and go, we need to watch this a little closer. So diversion of drugs, unlawful channeling of regulated pharmaceuticals, including the misuse of prescription medications. There's a lot of people out there with addiction. You do see diversion a lot of times due to economic reasons. When you can sell a Norco 5, you can sell one tablet for anywhere from $5 to $10 a tablet. A lot of times there will be some people that they'll take the chance of stealing medications and sell them on the street. So there is that. It's just not always addiction. Sometimes it can be economical. And so it's just a world we live in, and it's as long as there are humans around, somebody's going to try to do it. So I don't want to be put a bad light on everybody, but it's one of those things. It's always going to be an issue, but you have to have those processes set up to where you can detect it and then deal with it afterwards. Healthcare professions with the higher rates of drug use. I'm not upset here. Pharmacists are number 3. I usually like being number 1, but we've got nurses, dentists, pharmacists, anesthesiologists, and veterinarians. And it's all about access. And so, you know, nurses have a lot of access to, and I'm not bad mouthing nurses by any means, but they've got a lot of access. Everybody on this list has access to medications, and a lot of times, because of their professional certification, a lot of times they don't have any double checks sometimes. So it really doesn't shouldn't surprise you that there are people within those healthcare professions that have some issues sometimes. Preferred medications are benzodiazepines. That would be like your lorazepam, alprazolam, could be diazepam, and then of course your opiates. That would be Norcos, Percocets, things like that. Types of drugs preferred that shouldn't shock you. Opiates are, your Norcos are on the top of that, followed by the benzodiazepines like Valium, lorazepam, alprazolam, things like that. Sedatives, amphetamines, and then inhalants. Early intervention is vital for both patient care concerns and healthcare employee professional recovery. And I'll repeat this and over and over, but I will tell you that your biggest deterrent to diversion is that you have a visible program in place or a visible process. And a lot of people ask, what is that? And we'll talk about that. But just for an example, in my facilities that I go to, I always recommend you can vary it up, but the director of nursing, just go out and do a mid-shift check or an audit of the controlled medications. And it can be random. It can be one haul. It could be two hauls. It could be, but it needs to happen, twice a month, something like that. Just when, it doesn't need to be, every Tuesday at, 4:00. It needs to be varied. And if your staff sees it, if you've got a person in there that might divert, they're probably not going to because they just don't know when that check's coming. So just something to think about. 10 to 20% of nurses have substance abuse issues. The American Nurses Association estimates 6 to 8% of nurses are practicing while impaired. The big thing with that is, and when I see statistics like that, I don't want a nurse that's impaired taking care of my mother or any of my family members. And so that's a resident care issue if you have an impaired nurse in your building. So it should be, it is a critical piece that, if you do have an impaired nurse, you've got to really be, you've got to be on top of that because it's not just the nurse that's affected, it's the resident. And so that's kind of where my focus is on things like that. I care about the nurse, but I also care about the resident, and they can't provide good care if they're impaired. Substance abuse is the number one reason that state boards of nursing hand out disciplinary action. And then, one thing with the nurses, if they do go into some treatment, they have lower, recidivism rates when compared to the general population. Physical signs of use or withdrawal: hand tremors, headache, sweating, abdominal muscle cramps, nausea, diarrhea, irritability, or restlessness. Signs may disappear with use. These are always things to look out for. I'm not saying go out and examine everybody, but you'll notice people, and if you have a nurse that seems to repeatedly have issues, it's something that you've got to be aware of in your facility. And it doesn't mean they're diverting from your facility. They may have a problem and they're getting their medication from somewhere else. But if they are impaired, it's going to directly affect all the people they take care of. So it's something to watch for. Signs may disappear with use. They just may have some behaviors that really point out that maybe something's going on. Could be psychological, but it could be just the disease state of drug abuse. Staff behavioral indicators. One of the things I will tell you, and I talk to a lot of directors of nursing, and I've talked to administrators, and I've done this a long time. I've been a consultant, and I've seen it all. And I used to work in hospitals, and I've seen it all. And I've seen it from the surgeon that's diverting drugs for personal use. I've seen it, to the nurse. And, they all have telltale signs. But here's some indicators that, they don't really mean anything. Typically, I'll highlight a couple that I think are very, it should kind of perk your ears up if you see this in any staff. But isolates self from others, eats meals alone, avoids staff social events, frequent unexplained disappearances during the shift. One of the things that, and sometimes people, they think it's kind of a good thing, but these next two on here really, I don't know, they make me focus in on them a little bit to find out what's going on, and maybe nothing's going on, but it's good to be aware of it. Often shows up on days off to finish work or retrieve forgotten items. Frequently volunteers to work extra shifts. I will tell you that one of the things I have seen and seems to be consistent is people who will divert medications they'll volunteer for extra shifts, and typically overnight. And just because there's not as many people there and they have more opportunity. So a lot of time everybody goes, man, they are lifesavers, but it may be something else. Volunteer to hold the narcotic keys and perform a count. Frequently spills or wastes narcotics. Chaotic home or personal life. Refuses to comply with narcotic diversion investigational procedures, and implausible excuses for behavior or become defensive. Now, one thing that I will add, and one thing that I will, and I go back to those two indicators on this slide, frequently volunteering to work extra shifts and coming in at odd hours to finish up work, or, I left my purse, or, and it just keeps happening and happening, and or they're doing more work at odd hours. A lot of people, they don't suspect them. They just think, man, this person's a hard worker, and maybe they are. Maybe they are. But one thing I will tell you is that typically in these situations, especially if they've gotten away with it for a while, it's usually the people you least expect. And you can't always, you may think you know them, and it's, you just don't discount anybody when it comes to drug diversion, especially of controlled substances. It could be anyone. And so you've just gotta watch it. Resident care indicators: inconsistent or incorrect charting, displays inconsistent work quality with times of high and low efficiency, offers to medicate other nurses' patients on a regular basis. That's a bad one. Obtains large dose of narcotics when the ordered dose is available, documents the remaining amount as wasted, requests to care for specific patients. His or her patients reveal consistent pain scale patterns or complain that narcotics are not effective only on that shift. One of the things that I can do, and it's even good for the director of nursing to do, is to review the narcotic administration records. And it doesn't take long, but you can definitely see patterns sometimes that people just get pain medication when that nurse is working. And I typically see it, on night shifts or things like that. And it doesn't mean they're diverting it, but like I've explained to many people, regardless if they're using it to sedate the resident so they go to sleep and then they don't have to mess with them, that's wrong. That's a chemical restraint. And I've seen it. And so, you just have to look at certain things like that. And that's when we're talk about those checks. It's not a bad idea a couple of times a month to look at the narcotic administration record, and you can identify any patterns in there, especially with, certain nurses. The other thing is, offers, requests to care for specific patients. I would, if you have a hall that's strictly, a lot of dementia residents and people are always specifically asking to work on that hall, it kind of worries me a little bit because, a dementia resident can't, sometimes, depending on their cognitive ability, can't tell you if they've taken something or they got a pain pill. They just don't remember. So, and that's typically where you'll see diversion come into play, especially it'll typically be a resident who has dementia. Prevention and recognition of diversion and drug use abuse. I'll say it again, you've got to have a visible program, and because if everybody knows that you're constantly monitoring it, it makes them nervous, and they just don't think that there's too much risk involved. So you have to have adequate controls in place with your policies and procedures. And it should be, you're doing your shift counts, that everybody is adhering to doing those appropriately. Proactive approach for early detection and intervention, that would be, mid-shift narcotic check, 2 or 3 times a month by your DON, just in the middle of shifts. And, that gets people, they see it, and, and you don't have, your DON doesn't have to announce that, they don't have to be secretive about it. They just come out and say, hey, we're doing a narcotic audit, and we do these 2-3 times a month, and just to make sure everybody's documenting appropriately, and that word spreads fast in the facility, and they know if you've got one person in there that is even thinking about diverting, it may be, it's not worth the risk. Discourage diversion through education and awareness. If you have in-services, it would not be a bad idea to talk about, hey, we're all on board about, we do mid-shift checks, and we do that to identify any documentation errors or possible diversion, and, let them know how your facility, how y'all operate, and it's just a visible program for everybody to see. Intervene as appropriate, and rapid closure on diversion cases. I will tell you, when you do identify diversion, it needs to be swift action. One of the first steps, that your DON should take, and maybe at your direction if they're unsure what to do. If you detect diversion, every medication cart, controlled substances, all those should be audited at that time. And that goes for the controlled substances that are locked up waiting to be destroyed. All that should be audited to make sure that everything is accounted for. The next step would be, whoever the dispensing pharmacy is, you need to get a report of, if you've detected diversion on a resident, you need to get a report of what's been delivered within a certain time frame to know, well, how much on hand have we had versus on the narcotic administration record, how much is being said that has been administered. I always get this question about, do we call the police? Yes, you call the police. Once you identify and gather your data, you call the police and get a report and a case number for that. And I will tell you that typically the police departments are very responsive, and they take it serious because this is a big issue, especially with opioids. And so they can help you out, and typically they'll come in and do your interviews with people and everything else. So it needs to be swift, and it needs to be very quick, and just really, get to work on it when it happens, and it will work out. What I will tell you is that you do have to be sure, and there's processes you can take with a bunch of these, but just make sure it's a rapid reaction to any suspected diversion. And a lot of people don't like to involve the police. You should always involve the police in something like that. And the reason for that is, if medications from your facility have reached the public area and you haven't reported it to the police, it could be a really big deal. And so it's something that you got to be on top of, and know how you're going to react and put those things into place. Staff prevention strategies: only remove medications for your assigned patients, only remove current dose of medication for your patient, properly document medication administration and pain scores. All wastes of medications must have a documented witness. One thing I'll tell you in long-term care, typically you'll have CMAs, certified medication aides, administering medication. If they have to waste a medication, they are not going to waste and have a witness of another CMA. It's going to have to be their charge nurse. So they have to get their charge nurse, somebody like that, not somebody that is another CMA. Staff should never be a virtual witness. They should never loan their MedCart keys to anyone. Any medication discrepancies should be, reported to the pharmacy, as well as the DON. Attempted inappropriate access to medications to the pharmacy, and report witnessed or suspected medication diversion to the pharmacy. And you can reach out to your consultant. When it says pharmacy, I would do both. I would talk to the pharmacy consultant, and I would also talk to the pharmacy. Pharmacy can give you data on the deliveries of controlled substances to your facility, and then the consultant can give you direction on making sure all those steps have been taken to kind of make sure all the audits have been done and things like that. Examples of procedures addressing the disposition of medications: controlled substance receipt and reconciliation. We've talked about shift counts. Those shift counts should be, done and done appropriately. Timely identification and removal of medications. One thing that you'll see when facilities do mid-shift audits, the person passing the meds may not have documented that they gave the medication on the narcotic record. So the quantity's wrong, but they've given the medication. So that's a bad practice. I've seen it, and typically what I will tell a CMA or a nurse that has done that is that, one, you have to document it at the time of administration. And so, because then it throws into doubt, well, I don't know if you gave them that medication if you didn't document it. And you can watch a shift count. I've watched them in the past. You can see, if you see them doing their shift count with each other and then they're writing on the narcotic record, they haven't documented during their shift at the time of administration. So they're waiting till the end. You got a big problem, because we don't know, did that resident really get their meds? What if it's a dementia resident that has a very low cognitive ability? It'd be very hard to prove that they received the medication. So, because they can't say that they did. So it's really, documentation by the staff has to really be good. They have to do it at the time of administration. Identification of storage methods for medications awaiting final disposition. This is one of the things. Look at the process. What's the process of the medication when it's discontinued or a resident expires? What's the process from them coming off the medication cart to a locked area that only the director of nursing has control over? What's the process there? And so need to have really good processes for that. And to make sure there's no diversion. Control and accountability of medications awaiting final disposition. That would just be your DON, your director of nursing, having being the only one with access, but also I have in the past, I'll give you an example, and it seemed to work well. At a facility, they had some diversion, and it was diversion from the locked area that the DON only had access to. And one of the processes we put in place in that facility was once the medication, the CMAs, if something was discontinued or the resident expired, the controlled medications with the count sheets were brought to the DON. They both signed on the count sheet, and then the count sheets went to the administrator and were locked up in a safe. And when I would come in to destroy medications, when I was there on my console, I would get the count sheets from the administrator and bring them to the DON's office. We would unlock the door and then verify that the counts were correct as we were destroying. So that's just an example of kind of a process that we had to use for that facility going forward, just for their plan of correction. Documentation of actual disposition of medications, methods of destruction consistent with state and federal requirements, and procedures for discrepancies, theft, or loss. We talked about rapid internal investigation and closure of diversion incidents. Like I said, you need to contact your pharmacy. Any type of unresolved discrepancies, questionable resolutions, if there's anything that appears to be tampered with, syringes or vials, if you've got any missing narcotics or misplaced, or if you do have a diversion, you're contacting them for records of dispensing for a certain time frame, so you can kind of really zero in when the diversion took place, who was working during that time. The pharmacy can give you a lot of data so you can kind of focus in on a time frame and then who was working. This is like a checklist that we use internally at our pharmacy. It's not a bad idea to maybe a facility. I've had facilities kind of use this form as a guide and kind of do their own, just so they're going through a checklist of what they're doing, and they're investigating and resolving any type of diversions. And so this pertains more to a pharmacy, but you could alter it to be for a facility. So any questions on drug diversion? Okay, if anybody needs to get a hold of me, if you have a question or anything, you can contact me through my email. It's derek.sanders@remedyrx.com. So that would be DEREK.SANDERS@remedyrx.com. That's REMEDIRX.com. All right. Well, I thank you for the time, and everybody stay safe, and we will talk to you probably in the future when y'all are all administrators. Thank you.